everyone, and welcome back to another insightful episode of MedSynapse podcast series, where we bring you expert insights to transform patient care. I'm your host, Hetvi Shah, and today we're diving into adapting Western practices to reduce neonatal mortality rates. And joining me is Dr. Ajinkya Kale, a pediatrician specializing in neonatology. Beyond caring for premature babies, he's a passionate teacher, a researcher focused on infection control, an NLS instructor, and a candid mentor guiding future doctors worldwide. And his focus areas are the UK and India. So, welcome, doctor, and it is such a pleasure to have you with me for this conversation.
Thank you. Thank you so much, Dr. Hetri, for having me. Thank you.
To begin with, from your clinical experience, what are the primary causes of neonatal mortality in India today, and how do they differ from causes in Western countries?
Interesting. So there are four major killers, not only in India, but also worldwide. So the statistics differ from continent to continent and country to country, but largely there are four major killers. Number one is premature births. Number two is birth asphyxia. Number three is neonatal infections. And number four are congenital malformations. In the Asian subcontinent, and especially in India, prematurity and infections top the list. And very closely is birth asphyxia. Congenital malformations, yes, the proportion is around 7 to 10%, and babies do die because of them. But I think these three are major killers. And why do I say major killers? Because birth asphyxia, prematurity are sort of easily preventable in the way that we can reduce the neonatal mortality in that area. Neonatal infections, yes, scrupulous hygiene, and we'll talk more about it later, can help us reduce the neonatal mortality, but definitely deaths because of birth asphyxia and improving the prognosis of premature births is something that we can work on. If we compare these statistics in India to the Western statistics, especially in the UK, then the deaths because of congenital malformations and rare genetic disorders are a bit higher. However, in past 2.5 to 3 years, I would say, the neonatal mortality statistics in the UK is also showing deaths because of premature births. But this also has something to do with the changing guidelines, because now we also save the babies as early as 22 plus 6 weeks of gestation, which is still not a very common practice in Indian subcontinent. So that is my answer of the statistics between the Western countries and the Indian countries pertaining to the neonatal mortality rate.
I think that was such an eye-opening answer, doctor. And I think these gaps are really need to be addressed also sometimes. And I think India is also working towards it, if I'm not wrong.
Definitely. India is working towards it. What we were 20, 30, 50 years ago. Definitely the neonatal mortality has improved in the sense it has gone down. Okay, still there is scope that we can go down. That's why we are talking about it today. So neonatal mortality was skyscraping in 50s and 60s, around 30, 40 years back. We have shown a very, very good progress, as a developing country tag. We are doing very well in terms of all the parameters, including the maternal mortality and neonatal mortality. But still we are talking about it because still there is potential and still there is scope, which is easily, we can tackle it. Not with much efforts and not with much money and not with very eloquent and luxurious infrastructure. That's what
That's a very good, doctor. Rightly pointed out, doctor.
Yeah.
So now, doctor, could you please highlight some key neonatal care practices from Western countries that you believe have significantly reduced their neonatal mortality rates?
When we talk about neonatology, when somebody is talking about neonatal medicine or NICU, we instantly sort of imagine a very swanky, sort of a luxurious, posh ICU that we are not allowed to get into. Everything is very untouchable, infection free, which is true. That's how it should be. But it essentially does not need or does not mean a lot of money will save a lot of babies. Now, why do I say that? Largely, I have two live examples. Number one, when I was working in the UK, I was working in Liverpool for around 4 years and then in London for around 2 years. So what I noticed is wherever a delivery is happening, doesn't matter it is a level 2 unit or a level 3 unit. Level 3 unit is where all the high risk cases are delivered, and level 2 unit is moderately high risk cases are delivered. So, but doesn't matter where the delivery is happening, each and every person from the pediatric, the neonatal, as well as the nursing and the midwifery team are trained in neonatal resuscitation. They know how to give breaths to a baby within a minute. Doesn't matter whether a trained neonatologist is present at birth or not. That improves the deaths because of birth asphyxia significantly. And that is such a simple technique that everybody is trained in neonatal resuscitation. Do you require a lot of money? No. Do you require a lot of trainings? Yes. Correct trainings and only airway trainings. Let's start with that every birth that is happening in the country, there should be a trained personnel trained in at least airway. Okay, because once you open up the airway, the baby will breathe, and once the baby breathes, once that first breath goes within a minute. That's why there is a concept of golden minute, and I'm taking sessions at the grassroots level for ashas and auxiliary nurse midwives. I always give a motto, 1 minute 1 सांस, 1 minute 1 सांस, क्योंकि 1 minute के अंदर 1 सांस जानी ही चाहिए. That is the motto of golden minute, and that will improve not only the mortality but also the morbidity. My MD thesis, dissertation as they call it, was completely around cerebral palsy. So I've studied around 85 patients of cerebral palsy, and my heart breaks, when I see a easily preventable birth asphyxia, because it is so doable that you can just do a simple airway maneuver to give a breath. It doesn't matter whether it's a premature baby or a term baby, that you can definitely reduce the chances of birth asphyxia by knowing the correct techniques. So this is sort of the first thing that I noticed, which is quite easily doable over here, is what I think so. Because, thank you for a lovely introduction that you gave me at the start of the podcast. But what I also like to refer to myself is like a community neonatologist, because I'm doing a lot of trainings in Ghaziabad and Varanasi with a lovely organization called Community Empowerment Lab. So the name suggests it's Community Empowerment Lab. You are empowering the community. So our first step for 2025 first half is doing a lot of airway trainings. So I'm training the ashas, I'm training the auxiliary nurse midwives in sub-centers and community health centers and PHCs. Just do the correct airway maneuver, so that whatever is happening at your birth center, whatever babies are delivering, if required, you can give a breath and you can save the baby's life. And also you can reduce the morbidity. As they say, in neonatal resuscitation, only 10% of the babies that are born will require some sort of resuscitation. Out of that, only 1%, out of those 10%, only 1% will require extensive resuscitation in terms of chest compressions as well as use of drugs. Okay, so 99% are getting easily alleviated by simple airway maneuvers. Okay. Having said that, when you are going for a delivery, you don't know which baby, that baby is falling in which part. Is it the 90% or is it the 10%? You can have a prediction. Okay, all the antenatal scans are normal. You can hear the fetal heart sounds and everything seems to be going okay. That seems word is very important. That probably this baby will not have any problems, but he might or she might. Okay, the baby might. In that situation, you have to know. You can't wait, pediatrician, neonatologist, or somebody who can give breaths can come, because that 1 minute is gone. 60 seconds are gone. So how easy it is to train everybody in only airway maneuvers to start with. So that's the first thing. Second thing, I always give an example of the country of Norway. In Norway, in around 1840s to 1850s, the neonatal mortality rate was skyscraping. It was high. You can Google these things. It was in hundreds. And now it has come down to single digits in 2025. what is to ponder upon that in Norway, the neonatal care or the neonatal intensive care was only introduced in 1970, and still there is a deep dip, in the neonatal mortality rate. So what do they work on? Do you require expensive NICUs to drop the neonatal mortality rate? No, you do not. You just require at least a trained personnel at birth, to knock off that chunk of birth asphyxia deaths, which are around 30 to 35%, okay, in the country. So that's my answer. This is at least one or two things that are easily doable in the country, which are different from the Western practices and the Indian practices.
I think, yeah, those status actually sound so impactful, and I think just with little bit of training and the right training, kind of training, it actually says that golden minute is actually very true.
It is. So now that I've returned back to the
It's going to make all the difference, I think.
Definitely. Yeah, now that I've returned back to the country not many months ago, that is my, focus apart from neonatology that I practice. But I really want to develop a pool of neonatal nurses, because that are definitely a backbone of neonatology. When you're caring for a premature baby, when you're going for the deliveries, when you're discharging the patient, what kind of danger signs you pick up, because neonatal nurses are with the babies 24/7. A neonatal doctor will be handling around, 12, 15 babies together, depending upon what setup you are, private or government. But generally, you don't get as much time. You don't spend time with the baby. So now I've come up with a course called Neonatal Life Care, NLC. And you're going to start running it. We were running it informally, but now we have going to run it in a registered fashion. It's a one-day course where we do modules only focused on neonatology, because I'm a pediatric consultant and clinical lead in NM Wadia Hospital in Pune. So from this itself, we'll be running, and this course will largely be for neonatal nurses and junior doctors who are going to be on call and the first responders. That's my focus, because neonates don't give you much time. 10 seconds, they may deteriorate. So those 10 seconds, 1 minute, the first responder has to pick up, and it is quite easy. It is very easy. If I may, speak in Hindi, लोग YouTube video बना के noodles बनाने सीखते हैं. To save a baby's life or a newborn's life is much easier than that. You just need to know like 3 or 4 things, like airway maneuvers. If you know correct airway maneuver, vascular access, and keeping the baby warm, your chances are improving of the baby's survival. So hopefully with these, more and more people are aware, more and more people are trained, and the neonatology practices improve, and definitely the neonatal mortality rate will reduce in the country.
True, well, doctor. That's actually such a beautiful initiative by you also, I would say. So now, doctor, given the infrastructural and resource limitations in many Indian hospitals, especially in the rural parts, how can we prioritize or phase the implementation of these practices for maximum impact?
Beautiful. That's a lovely question. Thank you so much. So, when you go in the community, when I went into the community, you pick up so many things that you can do. You can work on infection control, you can work on asphyxia, you can work on improvement of the ultrasound techniques, you can, work on improvement of the, community outreach, how explain them what is a danger sign and how to pick up the danger sign. Do they give cards? Do we give them a call center number? You just are flooded with ideas, so you really have to prioritize in a way that you can impact at least one thing at a time. It is very easy to get distracted. I am experiencing that right now. It's very easy to get distracted, but what you really have to focus on is, number one, because there are a lot of cultural factors as well. When you go, in the rural area, when you're going and trying to make a difference at a very grassroots level in the community. So you have to take all those factors into consideration. Okay, when you're going in the remotest area, I myself have had that experience, that generally makes not allowed where the deliveries are happening. Okay, so it will not help if you are sending around 10 very trained, experienced neonatal male doctors over there, because they will not be allowed inside. So this is just an example that I quoted, and definitely the practices have changed, but still you have to consider a lot of things when you are coming up with what I call as a smart intervention. So what we are practicing, or what we are doing at the moment, is we are trying to tackle birth asphyxia, as I mentioned earlier, because that is a bit a low hanging fruit to pluck. Why do I say that? Because all the personnel or all the staff that are delivering the babies, we just have to train them with correct airway manners, and try to explain to them the importance, the gravity of prompt action. Why is it important? And make them do it hands-on. There are beautiful programs in the country called NSSK, like Navjat Shishu Suraksha Yojana, or Neonatal Resuscitation Program, that is basic. Okay, so these programs are definitely implemented at the grassroots level. Maybe what is lacking is more hands-on, more practice, more follow-up, trying to create peer champions in the community itself. Because once the instructor or once the organization teaches something to someone, and if they move on to the next city, they should try to keep a tab of what is happening in the village that they have just left, and how will they do that? Trying to create a peer champion. What is a peer champion? Peer is a kali. Peer is somebody from the community. She or he is a champion. So try to pick up such, try to, pick up and instruct a potential from within your candidates and empower her or empower him to instruct others. She will be the boss or he will be the boss, at least for the airway techniques in that village. Whatever goes wrong, she will keep teaching. I teach on another course in the UK, which is called as a generic instructor course. The name itself says generic. So it does not teach pediatrics or neonatology or something. All it teaches is the art of teaching, the art of simulation, the art of instructorship. So that's very important. You have to empower these peer champions on how to give a feedback, on how to instruct others, on how to train others. It's not only the technical champion that helps, it's the whole psychological and the emotional component of empowering a peer champion with instructorship. So coming back to your question of what we can do at the grassroots level or how we can prioritize things. So after pondering upon, and I've studied this since 1st of November, of where we can start, then we concluded that at least start with, something which is much doable, like birth asphyxia, because term babies are getting delivered, but they are getting asphyxiated as well. So let's start over there. Then we come to premature. Okay. And definitely this will have like a snowball or a compound effect. Because when you are in the community and trying to train airway, for example, then you are having a good contact with the community. You are having contact with the Asha. Asha is accredited social health activist. She was originally, the program was originally started in 2006. Her only function was to get a pregnant lady to the hospital, because we are focusing on more hospital-based deliveries to reduce the NMR. That has definitely helped. Now, poor Asha has so many jobs. She's involved in polio, she's involved in tuberculosis, she's involved in vaccination, health and nutrition days. There are so many responsibilities that she has, and they are doing a beautiful job, no wonder. But, as a hospital or as a doctor community, we have to go and reach out to them. Treat them as a human, treat them as a person, and try to understand what are difficulties they are facing. And then the next step is the ANMs who are there on the sub-centers. Just empower all of them with good airway techniques and a system where we keep a follow-up, where we also listen to them that what are the challenges that they are facing, because they have been delivering babies for a long time. It's not like if they are dumb or they don't know what to do. But there are some technical, infrastructural challenges that are there, and there are even community challenges that are there. So I think largely we should start with birth asphyxia. That will have a compound effect. Why do I say we have a compound effect? Then we'll also come to know a lot of problems like ultrasonography, whether it is happening correctly or whether it is not happening correctly, where they are going for their follow-ups, what about the blood investigation, what about the tetanus toxoid vaccinations, what about the iron supplements, the calcium supplements that are due, and the very basic, what about the registration, whether a pregnant woman is getting registered or not. Pre-marriage counseling, folic acid should be started 3 months pre-pregnancy, but that does not happen even in the cities. How we can expect to happen in a little less literate population, which are the rural area? So once, even if we just focus on the airway, we are still coming to a lot of things. That's why I say that it's going to have a compound effect, because then when we go to the next step, which I think should be prematurity, then we'll have a lot of more information, or we are a lot of more experience on how to train this staff. And then parallelly we are also working on infections, because hand washing, every time we go, we have to focus on hand washing. So these are all simple techniques that will reduce neonatal mortality to a great extent without having to spend a lot of money in infrastructure. You don't need a lot of fancy ventilators or ET tubes. What do you need? You need a bag and mask. That's it. You get it for 500 or 600 rupees even in the cities. You just need a bag and you just need a mask. That's all. So whatever PHCs are there, they all have bag and mask. But do they have the technique? Do they understand the gravity of when to use that? Do they know the concept of golden minute or a golden hour in terms of premature babies? No. Is there a closed loop communication? Whenever a patient is referred from point A to point B, he's just referred. Nobody is keeping a tab. Are pahunch gaya kya patient? What is the follow-up? So I think this is a very big behavioral change that we need to come around. So that's another answer to your question. What is different between Western and Indian practices? So I think behavioral practices are the whole, deep topic that we dive into.
True. I think absolutely. And I think bridging community and hospital-based care is also very essential for holistic outcomes, to be honest. So, Rakana, could you share examples of any innovative or low-cost solution that you have used or seen that bridge the gap between Western standards and Indian realities effectively?
So, as I mentioned earlier, largely we have been working with airway manuals. So when I'm doing trainings, I just focus on 5 steps or 6 steps that will correct the airway of a baby. Generally all these programs that are run in India or even in the UK, they start from the airway, then go to chest compressions, then they go to medication administration, IV access, vascular access, etc. But I have just limited myself to airway because not only that is the attention span of the candidates that do come, because there is a whole different topic of adult learning. They are not like, children anymore, that they will sit and do whatever you will tell them to. So adult learning is a subject that they will come, either they have been told to come because they are getting paid to attend, because or there is nothing to do, so they are attending. So there is a whole different psychology for adult learning. I'm not going to go into that. But what I have really benefited is keep it short, keep it focused, and try to make an impact at a very small and a niche level, and then go on. So if there is any, you're asking if there is any innovation that I'm working on, no. But what is innovative is the technique that we are trying to use. So rather than a more elaborative program, we are just focusing on one small technique and increasing the repetitions and increasing the frequency of the same, and trying to have a more deeper impact of a very small technique rather than a whole crowd of techniques that is generally taught in most of this courses. So that's the innovation that we are working on.
And I think that is so brilliant that such simple solutions which are practical, scalable and life-saving also. So that's into
Absolutely.
So now, Doctor, finally, what is your vision for neonatal care in India over the next decade? And what would be your key message to fellow pediatricians and policymakers?
So, India has done really well in last few decades. Our neonatal mortality is going down and down. And so is our maternal mortality as well. Okay, but still there is a big gap to be bridged. And also there is a gap between when you are living in a metropolitan city and when you are going like 100 kilometers away in the villages. So that gap is huge. Sadly, when there are beautiful, amazing NICUs and PSUs, intensive cares that are there, but you need a certain X amount of money in your bank account to have access to those intensive cares. We really have to ponder on how to sort of bridge that gap. The government hospitals, the government NICUs are overflowing are overflowing. It is difficult to maintain infections in such an environment. It is difficult to maintain the standard of care when you have huge volume of patient load, but still the doctors are working so beautifully and so amazingly. They always find a way to combat such a situation and try to give the best possible care. But obviously, doctor is a human as well, and each own limitations. So what would be my key message is, keep it simple, keep it small, and keep it focused. Okay, so you have a neonatal unit, you have a pediatric unit, you are working somewhere as a pediatrician or as a neonatal medicine specialist. Just try to ensure, this is step one, try to ensure that whoever you are working with, whether they are nurses or obstetricians and gynecologists, whether they are residents or they are senior consultants, they are well aware and well equipped with the knowledge of airway. So make your own goals. This month I'm just going to make sure that everybody around me is good in airway techniques, in the airway maneuvers, and how to give the breath. Okay, which is not very difficult, I promise you. It is all a simple jaw thrust, a simple maneuver of putting the head in neutral position will save a baby's life and will save the baby from a neurological disability, because for you it is just one of the 10 or 15 patients for the day, but for that family it is just one child for rest of the life. So you really have to put yourself in the community and the family shoes. So as a doctor, what I always think, that when I'm going for a delivery, whether everybody over there is trained in the airway techniques, everybody over there is trained in the hand washing techniques, everybody over there understands that why these steps are important. It's not only like going over there, do this, do this, do this, do this, do that. No, have a conversation, be polite, understand what are their problems. They will give you such answers and such insights and such challenges. You'll be surprised. It will be an eye-opener for you, because you don't spend time 12 hours on ground next to a patient on a shift. The nurses do that. The class 4 workers do that. You take the ward round and go away. So have empathy and just listen. Move around in the hospital with open eyes and open ears. Just try to absorb everything and come up with what I called as a smart intervention. And only one smart intervention per month, or maybe one smart intervention per 6 months. That's it. Baby steps. Okay, you can't change the world in one night. They say that Rome was not built in a day. So baby steps. Just keep it small, keep it simple, and keep it focused. There will be a change. Neonatal mortality will go down, and that is what I envision. That is what we are all here for, and we are working towards it. It may take some time because we are more than 1.6 billion population, but we will get there.
I think that is such an important takeaway for all the doctors, I would say, not just pediatricians or neonatologists. It is just from the ground level, from starting right from the patient level to the experts. So that was such an important thing.
Clarity begins at home. Just at home. Look at yourself. Look around you. Just that will make a big difference. You don't have to go to the community, each one of you, to make a difference. Don't go to the remote. Just start where you are.
Yeah, very true. Start with the ground level, doctor. So, Doctor, as we wrap up today's session, thank you so much for sharing your insights today. And it was such a insightful conversation with you about neonatal mortality also and morbidity as well. So, thank you so much, Doctor.
Thank you so much, Dr. Hetri, for having me this afternoon. It was a lovely conversation with you, and I'm looking forward for our next one.
Sure, Doctor. Same here. And to our listeners, stay tuned for more such enriching discussions only on MedSynapse. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay curious and keep making a difference.